Me aro koe ki te hā o I hene ahu one, mai te timatanga ko papatua noku te whaia whenua. Ko hene ahu one te ira tangata tuatahi, he wahine, ti hei mauri ora. Nau mai hara mai mō mātou whakaro, perspectives on Māori midwifery and maternity. Ko ai au, ko Kaniwa Kupenga tamarama tōku ingoa, he uri ahau no Ngāti Parau me Tainui hoki.
A tēnā koutou, he uri tēnei o ngai tāmanahiri, oro o pukata o ngai tarangi o ngā puhi a whānui tonu, ko hau Tupara tōku ingoa.
A tēnā koutou katoa, ko te whānau apanui, tōku iwi take, he uri hoki au no Ngāti Awa, Ngāti Rangi Nui, Ngāti Rangi, Ngāti Parau, Ngāti Whātua, Ngāpuhi, me Raukawa, ko Megan Tahere tōku ingoa.
We come to you today as Te Wakahui o Hene. We are a national organisation. We established in 2020. Our membership consists of Māori midwives and whānau who align with our objectives and values. To maintain connection, we hui on the second Wednesday of every month via video conference. Our rōpū objectives are championing an equal tangata whenua voice in the design and implementation of our focus areas, monitoring the direction of focus areas to achieve equal and equitable outcomes for tangata whenua, advocating for health system excellence in focus areas that prioritise tangata whenua and whānau ora, and conducting research that transforms focus areas to be tiriti-led. You can find more about us by visiting our website, tewakahuioohene.org.nz. Te tiriti o Waitangi is key to our Te Wakahui o Hene organisational objectives and values. We echo the wisdom of Matua Moana Jackson shared in this slide. Despite the promises of self-determination that Māori chiefs understood Te Tiriti to stand for, Māori have been subjected to assimilationist policies and structures. Māori childbirth and child rearing has been significantly eroded as a result. Te Tiriti is an enabler to the flourishing of all people in Aotearoa, New Zealand. Our timeline, from past to present, highlights the impacts that colonisation has had on whānau, Māori, our worldview and practices pertaining to maternity and the early years experience. In 1840, Te Tiriti o Waitangi was signed, formalising the equal partnership between Māori and the Crown. Soon after, we saw the implementation of Eurocentric and monocultural systems that commercialised papatua nuku, devalued our wahine and tamariki, and disestablished our healing paradigms and indigeneity. In 1865, the Native Land Act introduced the Crown-derived individual titles of land, which contrasted with Māori custom collective. The 1904 Midwives Act regulated the practice of midwifery, provided for the education and registration of midwives as a method to reduce the high infant mortality rate amongst Europeans, and thus help maintain the European population majority. This had the effect of privileging European pregnancy and childbirth systems. The 1907 Tohunga Suppression Act served different purposes. It was intended to control traditional tohunga whose practices were proving ineffective in treating introduced diseases. But it was also intended to stop people who were poor versions of the traditional healer. Although the Tohunga Suppression Act was repealed in 1962, conventional Western approaches continue to be prioritised over mātauranga Māori and te ao Māori models of care. Over the next 34 years, a decline in the health and well-being of whānau Māori is evidenced in the 1938 Committee of Inquiry into Maternity Services report, which will be further discussed later in our presentation. In 1975, the Treaty of Waitangi Act was introduced, binding the Crown to the establishment of the Waitangi Tribunal to consider grievances under Te Tiriti. Under the Waitangi Tribunal, the Y2575 Health Services and Outcomes Kaupapa Inquiry heard claims concerning grievances related to health services and outcomes, which are of national significance. The Stage 1 report was released in July 2019 and addressed 2 claims concerning the Crown's legislation for and administration, funding and monitoring of the primary healthcare system in Aotearoa, New Zealand, since the passing of the New Zealand Public Health and Disability Act 2000. In 2021, the Tribunal proceeded with its final recommendations for Stage 1 of the inquiry. Stage 2 is yet to be concluded and covers 3 priority areas encompassing mental health, Māori with disabilities, and issues of alcohol, tobacco, and substance abuse. We are paying close attention for the release of recommendations regarding the Y2700 Mana Wahine inquiry, which heard outstanding claims that allege prejudice to wahine Māori as a result of treaty breaches by the Crown. These claims extend across many fields of Crown policy, practice, acts, and omissions, both historical and contemporary, and of related legislation, service provision, and state assistance. Introduced in October 2021, the Pai Ora Healthy Futures Bill provides for a new structure and new accountability arrangements for the publicly funded health system in order to protect, promote, and improve the health of all people living in Aotearoa, New Zealand. The bill has just passed its 3rd reading and now will proceed to royal assent. The bill moves to replace the current 20 DHBs with one entity, Health New Zealand, alongside the Māori Health Authority, which is a recommendation of the Y2575 inquiry.
Kia ora, Kaniwa. In the current state, there are approximately 60,000 births in Aotearoa, New Zealand each year, and of these births, Māori comprise around 16,500 or 28% of the births. This map shows Māori birth events, which include all types of births from 2019. Just to give you an idea of the spread and concentration of Māori babies and births happening across Aotearoa, New Zealand. Māori women and babies are overrepresented in health inequities. In addition, Māori women and whānau continue to experience persistent inequities across socioeconomic determinants of health and risk factors that impact on their well-being throughout the maternity continuum. Midwives are key contributors to the maternity and early years workforce. There were 3,456 practicing midwives in 2021, according to the annual report of the Midwifery Council, which is the regulatory body for midwives. Since 2015, the percentage of practicing Māori midwives has been between 5 and 9%. Non-Māori midwives make up the majority of the midwifery workforce, and Māori midwives are severely underrepresented. The Māori Health Authority and Health NZ or Health New Zealand have agreed 4 key priority areas for the total population. One of those areas is kahutaurima, which is the 2 entities' joint approach to maternity and early years, or the first 2,000 days. When we welcome tamariki into our whānau and communities, we have a significant opportunity to make a positive difference through Te Ao Māori models of integrated care. This slide compares and contrasts the context for Māori childbirth at 2 points in time, 1938 and 2022, to emphasise the degree of change that has impacted Māori childbirth practices. These time periods are also impacted by underpinning health, social and economic factors that have contributed to wellbeing outcomes for Māori women, for babies and their whānau. For example, in 1938, birthing tikanga at a whānau and hapu level was well established. At this time, most Māori were birthing at home, which was normal and usual. By 2022, most Māori births are occurring in hospitals. In 1938, whānau birthing attendants were the norm. These photos at the bottom show some of the traditional whānau birth attendants. Right to the extreme left is Ria Tikini. She lived from 1810 to 1919. She's from Kaitahu, Kati Mamoi, Kati Huirapa. She was a tohuga midwife and healer, and the oldest person in Aotearoa at the time of her death. Next to her, holding the mere, was Mere Papa. She lived from 1842 to 1924. She was also from Te Waipounamu, Kati Huirapa, Kaitahu. She was also a tohunga midwife and healer and lived her whole life in Karitani. Next to Mere is Miriana Tangata. She was a nurse midwife. She lived from 1869 to 1929. She was born at Peria and served in Te Koiti Hospital and died at Manganui Hospital. And next to Miriana is Akinehi Hay, who lived from 1878 to 1910. Again, she was a nurse midwife. She's from Te Whakatohea, Te Whānau Apanui, Ngaitai, Tūhoi, Te Arawa, and Ngāti Pūkeko. She was born and raised in Te Kaha and served this area most of her life. Two photos to the right in 2022 represent that most Māori are being cared for by midwives who are not whānau. Due to the disproportionate number of Māori midwives to Māori birthing women, Māori midwives are in high demand as wahine Māori seek to revitalise their birthing tikanga and traditional birthing practices. In 1938, common health problems were scabies, impetigo, gonorrhea, mental health, dental, throat, skin, and general infections. In 2022, significant health problems affecting whānau are mental health, smoking, alcohol, drugs, and suicide. The timeline that Kaniwa showed earlier in the presentation highlights in 1874, Haimona Te Aotearangi petitioned government saying, "Alcohol impoverishes us. Our children are not born healthy because the parents drink to excess and the child suffers." Alcohol remains a problem on society with the addition of drugs, for example, methamphetamine. Health problems in 1938 were exacerbated by a range of other factors that occurred as a result of colonisation. For example, displacement from their traditional lands led Māori to depart from natural resources, including food sources for a wholesome diet and homes made from natural materials that were well ventilated. In 2022, the long-term impacts of preventable health problems have manifest, such as obesity, diabetes, cardiovascular disease, and mental health and addiction that can be attributed to intergenerational breaches of the Treaty of Waitangi by the Crown by failing to actively address Māori health inequities and failing to uphold its treaty obligations in the primary health sector. Kaniwa showed the timeline of legislation and actions that have had negative effects on the well-being of our people. She mentioned the 1865 Native Lands Act that had the purpose of extinguishing our own proprietary land customs The Act directly impacted the practice of locating built structures and unique places for childbirth, access to the land where we buried our pito and whenua, access to rivers and streams, and our land where we planted rongoa for childbirth that had pain-relieving, antiseptic or uterotonic properties. The regulation of midwifery in the 1904 Midwives Act privileged the childbirth knowledge and practices of others over the centuries of mātauranga of our ancestors. Midwives and the maternity sector must be clinically and culturally competent to ensure that they are not contributing to or compounding the inequities faced by Māori. We have a century worth of wisdom and knowledge informing us on what has not worked and what we have lost, and we need to reverse the past. The 1938 inquiry into maternity services followed on from an earlier inquiry in 1936 into abortion in New Zealand to understand whether the maternity services of the time could respond to rising abortion rates when New Zealand had one of the highest rates in the world. As a result of the 1938 maternity inquiry, comprehensive information was collected about Māori health, which included specific information about birthing. The information highlights the persistent inequities in Māori health outcomes and the needs of Māori that remain relevant to the reorientation of the health and disability system today. The report stated that modern maternity care of the standard rightly regarded as necessary in New Zealand cannot be cheap. The economic problem, therefore, appears to be not how the service can be cheapened, but how the individual in need can be assisted to meet these necessary costs.
A renewed health system should be centred on being tiriti dynamic. What this means is for us to place Te Tiriti o Waitangi at the forefront of all our thinking and providing opportunities to enact Te Tiriti articles in practice. In 2022, Te Herenga Hauora, or the Health Promotion Agency, hosted a national virtual hui that brought together public and population health leaders and practitioners to connect and reflect on proposed system changes, challenges, and future opportunities in Aotearoa New Zealand. The themes and views from the hui were brought together into a document that provides a simple, pragmatic, and action-orientated approach to public and population health in Aotearoa. It describes the notion of a tiriti dynamic system and suggests an agenda for government action. The Māori Health Authority and Health New Zealand both make reference to a tiriti dynamic and sustainable system in their planning. A tiriti dynamic and sustainable system requires 7 core elements. These are shared power, equitable resourcing, trusted relationships, community-driven priorities, tiriti dynamic workforce, robust data, and joint learning. Tino rangatiratanga is embedded in Te Tiriti o Waitangi and asserts the goal of Māori-led by Māori for Māori. This contrasts to the default approach whereby priorities and solutions are often developed for whānau. As we transition with the health and disability system reform, the amplification of whānau voice is really key to ensuring whānau maintain tino rangatiratanga over their own health. Current conventional commissioning places whānau as passive recipients of care and perpetually planned inequities, and sees Māori providers navigating highly specified contracts and output deliverables. So reorientation of the health and disability system is really requires an overhaul of current commissioning processes to ensure Crown prioritisation of longer-term trusted funding relationships with equal partnership between the Māori Health Authority and Health New Zealand and the two entities as funders with providers of health services. To flip conventional commissioning is to amplify whānau voice and prioritise the co-production of services and performance measures that will drive shifts in system conditions and result in public value ahead of unit cost, a notion that echoes the 1938 Committee of Inquiry into Maternity Services. Options for care and services need to flatten structures, equalise power dynamics, share power, emphasise reciprocity, and reflect deliberate investment for equity. Change is required to ensure there is investment in funding people, not issues, and achieving accelerated spread of Te Ao Māori solutions for Māori aspirations. There is much research that's been done with whānau who have shared what they need when they're accessing maternity care. For example, they've shared that they require care that is responsive to their cultural needs, is provided by Māori midwives and Māori service providers in Māori spaces, is inclusive of whānau and supports the revitalisation of traditional childbirth practices and empowers them to develop their own tikanga. The health and disability system reform really provides a platform for the Crown to strengthen system and sector responsiveness to whānau and for whānau aspirations to be supported through new commissioning approaches. For Te Waka Huia o Hine, we are really excited about the opportunities of the health and disability system reform, and using our organisational values, we've projected our hopes for positive future impact for whānau. These being, firstly, tūranga tiki tiki. So we expect that whānau will have access to timely care options and that this will be underpinned by conventional and mātauranga Māori evidence that is consistent with the intent of Te Tiriti o Waitangi by enabling whānau to be empowered to make decisions about their hauora. Secondly, whare kōhanga, that the midwifery and maternity sector will uphold our worldview as tangata whenua, and our values and the wisdom of our tupuna will be pursued to promote innovation and solutions that are based on Te Ao Māori. Thirdly, oha whenua, that the midwifery and maternity sector will be kind, that will practice manaakitanga and reciprocity to whānau. And lastly, hauhau I te rongo, that Te Tiriti o Waitangi will guide midwifery and maternity sector humility, respecting all people and their views and acknowledging that from time to time, people will disagree, but relationships will be mana enhancing, achieving equality and equity for whānau. One of the objectives of Te Waka Huia o Hine that Kaniwa mentioned earlier on is championing an equal tangata whenua voice. Rapua Te Aronga Hine, which was the first comprehensive research into Māori midwifery, was published in 2020 and highlighted the need for a tiriti-led midwifery and maternity system. For example, this would mean moving from colonisation to oretitanga, from mātauranga at the periphery to mana mātauranga, from under-resourcing to fair and deliberate investment in Māori midwifery and maternity, from cultural competence rhetoric to professional integrity, and from exploitation and disregard of Māori intelligence and technology to mātauranga Māori and Māori values at the core of midwifery psyche. Today's generation needs to enable movement from inequities of the past and present to revolutionary transformation that future generations will inherit.
The movement to date to reorientate the health and disability system is a step in the right direction. But to enable tangata whenua to participate equally in decision making that will properly eliminate inequities for the total population and achieve a truly transformed health and disability system in Aotearoa, New Zealand, a continuing national conversation about the constitutional framework that governs our country is needed. The Government He Pua report provides a plan to realise the government's response to the United Nations Declaration on the Rights of Indigenous Peoples, where, based on evidence, we would expect Māori wellbeing to improve as our authority over our lives increases. The report of Mā Tike Mai Aotearoa, the Independent Working Group on Constitutional Transformation, presents 6 different models for a new constitutional arrangement that are the good basis, the foundation for a national discussion on ways to improve our authority.
The opportunities are limitless, and we leave with you a whakatauaki from the report, Raporte Aronga Ahine, that refers to the creation of conditions that enable our generations to flourish. The analogy that is used in this whakatauaki explains that when the pingao is healthy, the dotterel will nest. Pingao ki te tū, tūturi whatu ki te tai. This connection between this whakatauaki and our presentation is that we must be the architects of our system for our whakapapa to thrive. Hei whakamutunga, he mihi kau atu ki a koutou e mā takitaki mai nei. E te papatonaku, kua motu tātou e te tahi o te rā, mahitahi o te rā, kia tau te rangi Māori e kei mātou, haumi e, hui e, tai ki e.